Um, we will now transition to our stakeholder presentations looking at the impact of COVID-19. One of the most important parts of our discussion is to understand the frontline impact of the community most affected by COVID-19 throughout the state. We have 3 presentations today. First by Melanie Barlow, the Medicaid Outreach and Enrollment Specialist at Central City Concern. The second by Dr. Castaneras, a family physician and Mid-Columbia community volunteer. And the third presentation is a combination from Wes Livaday, Health Systems Analyst for Oregon Office on Disability and Health Executive Director for Oregon Spinal Cord Injury Connection, Christine Getman, the Executive Director for Magic Wheelchair, and Crystal King, Disability Advocate for the Portland Disability Justice Collective. We don't have public comment, so if we keep our presentations under 15 minutes, we'll have about 15 minutes for discussion, and we would like to reserve 15 minutes at the end of the meeting just for some wrap-up comments. So I'd like to welcome Melanie Barlow.
Hello. Hopefully you can hear me okay.
Yes. Thank you.
I really appreciate this opportunity to speak with you all today. Right off the bat, I'm going to say there's so much that we're doing right, but there's so much more that we could be doing that would be righter. I did want to talk about the mental health issues that the homeless in Portland are facing right now, and some of the other barriers that homeless are experiencing as well. But the mental health seems to be the biggest issue right now for us. We're having a lot of relapse with the community that we serve with their drug and alcohol treatments because they just don't have access. They don't have access, whether it's to technology or to understand how to use the technology, even if they have the technology. One of the things that I laugh about is, you know, we've made a huge effort to make sure that people have phones, and that's great. A lot of them don't know how to use the phones, especially the smartphones. And then when they do finally figure it out, hopefully it's with help, they don't have a place to charge the phones. So we're running into big disparities there where people would have access to things like telehealth appointments and being able to communicate with their providers without having to step into a clinic, but it's not happening because of these barriers. With the COVID-19 response, many of the things, the services that we offered to the homeless, hygiene, refuge, whether it was just respite from the weather for the day or, you know, a night in a shelter, it's more limited than it was before. So we have these barriers as well. And I just know that there are things that we can be doing better than we're doing now. Specifically, I do want to go back to the telehealth issue. Telehealth is huge, and it's a huge issue for our homeless people because, like I said, they have, many of them, no telephones. And we can supply telephone after telephone. But if they don't have a clear Wi-Fi connection, or if they don't have a secure location where they feel like they can speak freely, issues aren't being addressed for them. And they're just falling through the cracks. People are walking around with bigger issues because they're feeling like they're not getting heard, and they're not being heard because a lot of them close down more when they're having a crisis. And we need to be able to provide more feet on the ground. As an outreach worker, it's one of the disparities that I cringe at every day, being able to reach out to people and making sure that my clients' needs are being met. I feel like I wish I was an octopus, and I wish there was a way to clone myself, and I'm not anything special. I don't know of a person that's in mental health right now that doesn't feel overwhelmed and stretched and like they wish they could clone themselves because there's so much more that we could be doing. Don't think there was anything else I wanted to talk about. I know that 15 minutes was given, but I had to actually just pull over because I'm going between locations right now. So I just wanted to know, I want you to know, and I want to know what we can do with this technology disparity that there is going around. I know that we have a waiting period. I've seen people get told we have about a 3-month wait period right now for mental health issues. And if you're in crisis, even if you don't say that you're in crisis, a lot of people, when they hear that, they close up. Like I said, they close up a little bit more, and then they're not going to reach out again because they've already done. It's taken so much for them to reach out. If you have a person that's in the midst of or on the border of having a psychotic break, to be told, I can't help you right now, come back in 3 months, you know, that sends them spiraling. And then that's going to overload our hospitals and our prisons, our jails, because they're going to have some kind of issue. And what's going to end up happening is they're either going to end up in the ER because they were picked up and brought in, or they're going to end up in a jail cell because those are the solutions that we have. Or they're going to walk around in the streets banging their heads with their fists because they need help and they don't know what to do. And they don't know how to reach out because they've already spent all of the energy and the capability that they have to be able to do that. If we had secure locations, even if they were portable, out in the community where people could come and charge their phones, where people could come and talk to a mental health provider, I think it would make a huge difference in the mental health stuff that's going on with COVID, without COVID, in our homeless community. I believe that our medical stuff, our medical side is really getting a lot of attention, and I think that they're doing a lot of, I think that it's right on par with where it needs to be. But specifically the COVID, the BIPOC response to the COVID, mental health, things that are services that are being offered, I know that there's a lack and that we're working on it, but there's other things that we could be doing, and I just wanted to let you know that.
Thank you. How have you seen your caseload change in response to the economic loss and sacrifices that people have endured through COVID?
My primary role is signing people up for OHP, and then like referring them to do things, to services, like if they needed help finding a provider. Since COVID hit, I would say there's probably a 90% increase in people asking about mental health services where they weren't before. Specifically, I'm already talking to people preemptively, excuse me, about services that are available to them and where they can reach out to them. One of the biggest issues I have, though, is being able to get service and help in a timely manner. I've also seen, like I said, with the people, my coworkers and cohorts that work with drug and alcohol treatment centers, the increase is big. Their caseloads have increased. The referrals that I refer people to these services has increased, and the abilities that my coworkers and cohorts have to serve these people, you know, it's smaller and smaller with each added case.
Thank you very much. Other questions for Melanie?
I don't know that I have a question other than just really deep and sincere, profound appreciation for you and your work. And I know that the communities that we serve benefit from advocates like you who are saying we're doing a lot and there's just more to be done. I know the question around how we look for structural solutions to the pandemic is not specific to, as you mentioned, just COVID. It's around the resourcing for behavioral health in general. And I appreciate very much the potential solution that you offered us around more secure locations where telehealth and services can be made available. So I just really want to thank you for making yourself available to talk to us today.
Yeah, it's one of the questions that I had, you know, like if in the middle of downtown Portland, where access is literally, you know, just a connection away, if we're having the struggles in downtown Portland, I can't imagine what any access to services is like out in rural communities. So there's got to be more. There's got to be better access to the Wi-Fi. There's got to be more knowledge. Being able to teach someone, I mean, personally, I have at least 5 people that I can name that have, for whatever reason, never used a smartphone before and literally barely know how to turn it on and off and answer a call. Asking them to connect to a Zoom meeting for a telehealth appointment, I might as well be speaking Martian. And then if you add a language barrier to that, specifically with the Hispanic population, you know, it's very difficult, very difficult. And then, you know, like with the Hispanic population, I'm looking at just people I know, they're always going to end up handing the technology over to their kids because their kids' school is more important than an appointment. So maybe better and more access for people like that. And thank you.
Other
And
comments
if
or
there's
questions?
nothing else, yeah, go ahead, sorry.
I'll just inviting any other comments or questions from the group.
Thank you, Melanie, for your work.
Thank you. Bye.
Well, I want to thank you, Melanie, for your great work, and also congratulate Central City Concern for the great work your organization does and for supporting them. Really one of the
Thank you.
providers in our community.
Thank you. I'm so proud of us.
Yeah, we
Thank
all
you.
are. All right.
Bye.
Bye-bye. I would next like to welcome Dr. Castaneras.
Hello, can you see me? I can't tell if my video is on.
Not yet.
I might need staff to turn it on. But I will go ahead. There are slides that will be shown by staff there, I think.
Your video button's in your lower left-hand corner of your screen.
I have it on, but somehow it's not showing.
Okay.
Do you see me?
We do not.
Well,
we can hear you fine.
Okay, let's go ahead because I have slides that hopefully the staff will just put up. Can we see those?
Steph or Michelle, they're great. They're
okay. All right, sorry that you can't see me. I'm not sure why. I'm Tina Castaneras and I'm a retired physician and I'm a consultant. I've lived 36 years in Hood River. And I know some of you, and I'm very honored to be able to address you today. So thank you, Chairman Bangsberg and all the Health Policy Board and Director Allen and all the staff. I was recommended, or my name was put forward to speak with you originally, I think, because of my advocacy for the protection of farm workers and food processors during the pandemic. I understand you've had a presentation last month on that subject, but Tara and I, then corresponded, and I explained that being retired, I couldn't really speak from personal experience to questions about the pandemic's impact on, say, my patients or my clinical practice. But when I shared what I could perhaps convey about the pandemic, about food system workers and other vulnerable populations, Tara was kind enough to invite me and suggest it still might be valuable to you. So I hope so, and I hope I can justify your giving me this time. You're a pretty august group. Next slide, please. So I'm sort of, you could say, a kind of Forrest Gump of health and public health, healthcare and public health. And I won't belabor you with this, but I just wanted you to understand, I understand quite a bit about healthcare and public health delivery, healthcare financing and policy, rural care, the social determinants, and community health work, as well as being a consumer like we all are of healthcare. Next slide, please. So during the pandemic, I've actually been working about 20 to 30 hours a week as a volunteer as in the community. And I'd be glad later, if you wish, to clarify about what I've included in that slide and the last one about what I have been trying to do in our rural community or help with. I guess I want to just interject, having listened to your conversations earlier today, one thing I've been so impressed by in being a community volunteer on Zoom is how many new young leaders I have met in my community that I was not acquainted with, who are leaders of color and representing different constituencies than I think we've had in the past. So I'm very gratified by that, and I think it speaks to some of your earlier conversations today. But let us get to what I really want to share with you. Next slide, please. I understand that your work and that of one or more of your committees or task forces involves gap analysis. And as a healthcare administrator in the past and a consultant and the chair of a health philanthropy, I have always felt strongly that identifying failures or pitfalls or missteps and lessons learned, both early and in hindsight later, is really vital to the work we do. So to me, that's the meat of gap analysis. In addition to what do we still need to do, there is what do we need to correct right now and before the next time. So going to the bullet points on this slide, I'd say first I want to acknowledge this pandemic fell like a curtain on normal life, as we all know, and really a globally unprepared public health system. So it was a sudden catastrophe, it was unexpected, and it's changed everything, as we know. And consequently, I really earnestly want to appreciate the hard work that the Oregon Health Authority, the Governor's Office, all of our public health departments and community partners have done and are doing, and the good outcomes we've seen. I'm very aware of public health being under-resourced for decades, and it's amazing what's been accomplished. I feel very lucky to be an Oregonian and still safe at home. But as Melanie said before me, Oregon, we're doing great things, but we can do better. Looking back, I think it's understandable that the focus everywhere was on the healthcare delivery system, especially in hospitals and then clinics. Everyone was worried about the severity of this terrible illness. But also, I think looking back, it's really important to acknowledge that some of that was done at the cost of doing adequate upstream public health and population approaches, doing demographic analysis that was very focused and drilled down on those who would be most vulnerable, and having an equity lens. It's been really nice to hear so much about equity in your meeting today. I'm very appreciative of that. We've learned, I think, now that protecting the public, the general public, and then especially vulnerable groups from infection, that's really what reduces outbreaks and protects healthcare workers and hospitals and clinics and reduces the need for the kinds of supplies that we were quite concerned with from the beginning. Another thing I think was a difficulty was that we took a very narrow definition of healthcare workers that excluded, say, hospital custodians and people working in home health or folks going into homes with vulnerable elders day by day and taking care of them, or those who had disabilities of any kind. public health nurses, and so forth in many cases. The next slide, please. So, next slide, if you will. So the $64 million kind of question is this: what have we learned and why is it so important? So I think we always need to really articulate the lessons learned so far and be very transparent about that. And then we need to apply them. And we need to apply them right away for some vulnerable people. And we're going to need to apply those lessons in coming months. And importantly, we're going to need to be able to be set up for the next epidemic of infectious disease. Next slide, please. So there are some very important, nope, that's the previous one. Next one. And then the next one. There we go. Some important lessons about the elements that have eroded trust and in fact may have cost lives. I've tried to capture here from my perspective. I think we had potentially preventable outbreaks at workplaces and congregate settings and crowded conditions and labor camps and in lieu sites for Native Americans and prisons, in the sense that we did not adequately and proactively identify these groups and these settings. We didn't really keep them top of mind. Consequently, we didn't supply them. We do not as a society adequately regulate these sites, and we don't enforce the regulations that might protect people. And I realize that's not all in your wheelhouse, but I want to just surface those, what to me are facts. We have had provided as a society very confused messages, as we all know, about or conflicting messages about PPE for community members and high risk groups. You know, should you wear a mask at all? Well, no. Well, yes. Face shields versus masks, cloth masks, or masks for my protection or for my protecting you. All of those things have actually really eroded trust, and I think we know that. And we've had a really important lack of screening testing and proactive targeted testing, which remains true and I really feel needs to be corrected as quickly as it can be done. Similarly, there are very big barriers and problems with contact investigation and how test results are delivered. I think it did not occur to us as a society that this is sometimes tantamount to delivering bad news, like delivering difficult diagnoses for end of life and so forth. I do think, and this might be controversial among you, but I'll put it out there, I think we have an over-reliance on the community-based organizations and FQHCs. I think they're very important. This is where my whole career and life have been most. We could talk about that, but some of this really is properly the role of traditional public health. And it's really, I feel, a strain to ask CBOs and FQHCs to always fill it in. And finally, what I wanted to share is I think there's been very inadequate data collection about race and ethnicity, and especially about occupation and living situation. And again, we could talk about that, but it's come up. I participate in pretty much all of the statewide clinicians meetings, and this comes up again and again, but we're still having trouble getting a handle on that. And without really knowing if a person who's in contact, say, or even a positive case of COVID is a bus driver or drives a senior van, without knowing that kind of thing, we really can't take proper action in identifying the trouble spots. And then the next slide, please. And finally, I think that an element, oops, one more back, thank you. Just basically an articulated early strategic or systematic plan for the most vulnerable groups. At least we didn't feel that, at least speaking for myself, I did not perceive that in my rural region, where we really saw that there was a strategy around childcare and education providers or elder care and home care providers early on, or other folks like food bank and Meals on Wheels, and even public health staff, or non-clinical hospital staff like custodians and others. And of course, farm workers and food processors, factory workers, and Native Americans and Indigenous people, people without shelter, folks with any number of disabilities, and elders. I think we just didn't see that a strategic plan needed, perhaps, or we weren't able to articulate that as a society. And I know this starts at the top as well, not just at the state level, but if we can begin to do that more, I think we'll be better set for the coming months and for coming epidemic. So next slide, please. So I do think, whoops, one more back. Right now, I do think that public health, traditional public health, has got to offer free screening tests to vulnerable groups and encourage them. I don't think they should ever be forced, frankly, but they should be offered and encouraged initially, and then at intervals to everybody below. Some of this, like testing, screening farm workers on arrival at site, is something that's in the OHA guidelines and is in the CDC guidelines as recommended, but we're not comprehensively offering those. They also need to be accompanied by employer buy-in. If employers don't assure workers at factories or food processing plants or wherever that they will not be penalized in any way if they test positive, that they will be protected, we need that kind of encouragement, and that really requires working with employers to do it simultaneous with testing. And when there has been a positive test or contact investigation, it really needs to be culturally appropriate and trauma informed. And I think that is something that needs to be powered up now. So I mentioned the folks, and I would add to the little list I put at the bottom there, incarcerated and those who are served at home with chronic illnesses or any disabilities, as well as in facilities. Next slide, please. Going forward in the coming months, I think that there are three kind of main things we should have on our radar. A second wave is still definitely possible, even when we see things settle in this initial few months. The next impact season, and by that I mean for agricultural workers and for tourists, is really important to be prepared for. And of course, vaccine distribution. I didn't put on there, but it's scientifically certainly possible that we'll see a different strain of this virus really producing almost a different epidemic. But at least these three things I think we can count on being an issue. So what we need to do is plan together, both healthcare together with public health, for upstream interventions. I love Dr. Berwick's famous quote, "The best hospital bed is the empty hospital bed," or words to that effect. And we can only get there and reduce burden with future problems on our healthcare delivery system, especially at the hospital level, by doing targeted and widespread testing and very strategically done contact investigation and support. We don't see the food processing season ever stop. It's not an impact season thing. Food processing goes on year round, and fisheries and so forth. And the risk doesn't stop either for other vulnerable groups. So we have other possibilities on the horizon to really be planning for. The next slide, please. And then equity. How will we deal with distribution of the vaccine? Some of these elements, whom will we prioritize? How do we foster trust? They've been mentioned today. How will it be affordable? What do we do for appropriate cultural outreach? What's fair? All of that. Because vaccine distribution and encouragement is ripe for propagating inequity if we don't do it right. And again, something I'm sure that is on your minds and already in the works. Finally, the next slide, please. So all the things plus a lot, whoops, the previous slide, please. All the things that I mentioned and a lot that I'm sure I'm not creative enough to think of need to be institutionalized. I think the next time around, it definitely could be measles from low vaccination. It could be cholera after the water supply is compromised after a major earthquake, or it could be many things that would be a next infectious disease epidemic. And we can count on the fact that given the population and transportation networks in the world, it almost certainly there will be another global infectious disease. So the 3 questions that Tara was kind enough to send to me that you might like to be addressed by me today, I understand, I hope you understand that I do not represent a provider group or organization. I just represent myself and my perspective. But my concerns on the first question about Oregon's response in the near future and midterm future to COVID, I think I've covered that. Health inequities, a huge amount of work in my community is being done by numerous community partners, including the social service agency, the Next Door, One Community Health, which is our Mid-Columbia FQHC, Oregon State University's Extension, and many others. I certainly don't want to understate how important the CBOs have been in really doing the thing they do best, which is reach into the community and serve the community in the social service and healthcare world. That really is probably the most important single strategy for reversing or preventing health inequities. So I'm so glad that you work closely with CBOs. And then finally, what the question Tara sent me was, what's the role of hospitals in my community? And that's a hard one for me to answer because the CCOs certainly have unified hospital voices and efforts with those of other clinical practice and even public health. Mission integration efforts have been ongoing, and those are so important in the larger community. But I think too, it's understandable that hospitals have had to kind of hunker down to engage perhaps more than ever in their own practice readiness and the clinics that they own. And of course, most hospitals own many physician practices. So they're, if anything, maybe a little less engaged than they might have been before the COVID pandemic in creative mission integration work. So those were my thoughts about those 3 questions. And next slide. I just want to earnestly express my thanks to you all for what you've done. You've kept me safe. I needed that. And if there is time, I'd love to engage with any questions to clarify or hear your own comments. Thank you again for your time.
Thank you, Dr. Castaneris. Appreciate your comments. Any thoughts from the board, comments or clarifying questions? I certainly want to appreciate and underline your comments on moving upstream. You know, we spend a lot of time focusing on preparing our hospitals and ICUs, making sure we have enough ventilators for COVID-19. And really the hard work was really the work of Oregon Health Authority in developing the policy framework and implementing that policy that kept the hospitals empty. So I think that I really appreciate you underlining that. Kirsten, and then John.
I just want to thank you, Dr. Castaneris, for your significant volunteer work over this time. And I also just wanted to say how kind of true it rang, some of your statements rang home for me. I spend my other amount of time working for a labor union, and we definitely had a lot of frontline healthcare workers, and whether they be patient registrar or EDS workers who were experiencing things, but not able to switch to, say, plastic clipboards that they could sanitize, and we're still giving patients cardboard clipboards and trying to raise flags to be like, wait, there's other steps that we can do here. How do we have our voices heard? And also your comment about the role of employers hand in hand with testing and what comes next. And I think our state is in the midst of some significant rule developments with OSHA right now. And we cannot underestimate the role that fear of employment or not being able to house or feed your family plays in the decisions that you make. And so I just it rings true, and I think stories are important, and as we come improvements.
Kristen, you're breaking up. We didn't hear the end of that.
Kirsten, you're on mute.
Oh, sorry. Sometimes my internet gets bad. I look forward to us learning from these experiences. So thanks for sharing.
Thank you for your comment. John, you had a comment?
Yeah, Tina, thanks so much. I'm like you, I'm almost 70 and, not associated with any organizations. But I want to ask you, to what degree has the private side stepped up here? Are workers' compensation companies stepping up to the hazards that the frontline workers they're responsible for are facing? Are private insurers in your community stepping up and saying, well, actually we're in good shape, and here's what we're doing. We're returning money to employers. We're returning money to individuals. We're using the resources we have to try and help. So do you have any impression of what's going on from a private side point of view in your community?
Thanks, John. It's nice to see you again. I think that first of all, I may not be in a position to have seen that waterfront, but on the farm workers side, orchardists and farmers in our community have been involved in educational sessions, and some have invited RFQHC and Extension to give education to workers and so forth. And that's been quite gratifying. You mentioned a few kinds of players. I haven't seen anything come forward from workers' compensation per se, and in terms of insurers, certainly Pacific Source is quite involved in all of the CCO discussions, which then touch on this, to say the least. So, because our CCO is Pacific Source Fiscal Agent. But I haven't seen private business come forward with funding, for example, for the most part. Some exceptions, some businesses purchase PPE for their food processors early on, others did not. So it's varied, but I haven't seen that as a force. The business community in the Mid-Columbia is very involved, as you might imagine, not only with agriculture, but with tourism. So reopening has been a charged issue here because tourism has been our secondary moneymaker for the counties here. So I guess I can say that I don't know, John. I would love to see more private enterprise funding some of the efforts that have to be made, but I haven't experienced a lot of that so far.
Thank you. Oscar, you had a comment?
Yes. I had a question. You talked about sort of kind of wanting to have a much more clear strategic plan for some of the most vulnerable community members in your region. And you sort of said, at least in my rural region, you didn't sort of see this very clear strategic plan. And certainly something that we heard last month as well from a provider that's, in Washington County. So there's definitely, this sort of theme that we're continuing to hear. Can you talk a little bit more about, where you were looking for this sort of plan, and maybe talk a little bit more about, in terms of like where you got your direction then if you didn't see this strategic plan?
Sure, and thank you for the question. I'll do my best. Let me give it, I can do best with examples. And again, it's not that I have a comprehensive view of everything here, but we're into month 8 or so now, month 9, and we're beginning to see that there will be screening of staff and residents more uniformly at elder care facilities. but we would have been great to have seen that plan and see it implemented some months before. And as I understand it, there are even caveats about that plan that will exempt certain facilities and certain workers and even perhaps inspectors. So that's one example. In the farm working and food processing industry, where I'm most familiar and have the most experience with, it would have been, again, really a great thing. And I think we should remember that for gearing up in the coming months to have food processors really universally protected and tested since they work in close quarters, and then arriving seasonal farm workers protected and tested on arrival because of their living, if not working in close quarters in labor camps. The OSHA regulations that protected or did temporary rules to protect farm workers in labor camps, at least in my opinion, did not go far enough, and they will expire in about a month. So I think a really big overarching view that would have somehow articulated, okay, farm workers live and work in crowded conditions and food processors do too. We need to be testing them frequently. We need their employers on board with all of that. We need to have culturally appropriate persuasion for getting tested and reassurances for protection with wage and family and jobs and so forth. Those kinds of things unified in a plan would have been great to see at the beginning. Without that, we've had some terrific efforts at the state level. There is a migrant and seasonal farm worker task force that's really very good, that educates us in the community. But we haven't seen the direction that would really, from the state, for elders, for farm workers, for Native American folks, for folks living in facilities and congregate settings, or for prisons, I suspect, even though we have no prison in my community. So those groups would have been really great to identify early and have a plan for testing, contact tracing, protection, PPE, follow-up. And we're still struggling. So I'm hoping that those things, the elements that made us struggle, can be corrected before the next coming months. I hope that answers your question.
Appreciate your time and expertise, Dr. Castanero, for sharing that with us. Let's move on. I'd like to welcome Crystal King, Christine Getman, and Wes Livaday. Just a plug for the OHSU PSU School of Public Health. Wes is one of our alumni. We hand the floor over to the three of you.
Thank you, Chair Bangsberg. We'll be brief or quick, but try to be as thorough as possible. So my name is Wes Livaday. I am a health system analyst at the Oregon Office on Disability and Health at OHSU. I'm also the executive director of Oregon Spinal Cord Injury Connection. And I recruited Crystal King and Christine Getman to join me today, and we'll be keep to our time frame here. But I invited them to help me give an more expansive perspective on what's happening in the disabilities communities, because we don't represent everybody. I have a spinal cord injury through a hospital infection in 2013. And what I'd like to share with you today is that what we're experiencing in the disabilities communities is a disruption in services and resources due to COVID. We're also experiencing stigma and discrimination as we access healthcare in hospital and clinical settings. We've also experienced systemic barriers that create obstacles, barriers, and prevent workers with disabilities from getting access to care. As was mentioned previously by, I believe it was Melanie from Central City Concern, there's tremendous technology barriers among the population of people with disabilities that live in poverty, which is about 3 times higher than the general population. Community-based organizations are not able to hold their fundraisers and are experiencing staff cuts and funding cuts, so which is further exacerbating access to care in regards to disruption of services and resources. What I've also heard is that individuals that are on SSI or SSD are using limited resources to purchase PPE gloves, or they're reusing gloves, or they're not using gloves to do procedures, daily procedures that help keep their health stable in order to not acquire an infection, a UTI or an acute respiratory infection. And let's see, additionally, there's a higher demand for PPE. And so being able to access those is more difficult. Additionally, limited access to technology. There are caches of PPE available at the county and the city level in Portland and North Oregon area, but due to the foreign nature of smartphones and access to the internet for some of our population, being able to find those resources through technology is just, it's impossible. It's finding a needle in a haystack. And then Crystal King will share about the stresses that personal care attendants are experiencing and how that is also putting a stress on our population. So that's what we're experiencing. And then generally, I'll say what we're needing, what we're asking. We need the Oregon Health Authority to enforce the rights that people with disabilities have through the ACA. I'm sorry, through the ADA, Americans with Disability Act. We need community input on the crisis standard for care document that has been recently circulated. I particularly came aware of it through the Health Equity Committee for the Oregon Health Policy Board. And then we need work opportunities to be expanded for people with disabilities by eliminating the asset and income restrictions for workers with disabilities that are eligible for Medicaid. Lastly, we need more providers with disabilities in our healthcare settings. There is generally systemic barriers for educational attainment and employment, which people with disabilities experience, and therefore we don't see providers, nurses, healthcare workers with disabilities, and it's not prioritized even in some of the conversations we talked about earlier today that I heard about the OHSU offering funding for people with BIPOC populations to go through medical school. So I'm going to stop there and ask Crystal King to share her experience, and then Christine Getman. And Crystal and Christine, just be mindful of your time as well. Thank you.
All right. Hello, my name is Crystal King, and I am here representing the PDX Disability Justice Collective. I am autistic. I am the founder of a group called Autistics and Allies for Ethical ABA, and I work in both behavioral therapy and home health with children with physical and/or cognitive disabilities. I'm grateful for the opportunity to be here today to shed some light on what's been happening within my community. I have one home health client. She's sweet, she's intelligent, she's expressive, she's creative, she's incredibly aware of what's going on around her. She is also medically complex with significant cognitive support needs. She has a number of medications to balance throughout the day, and at any given time, she's enrolled in speech therapy, physical therapy, and behavioral therapy. She has an extensive care team that includes all of her therapists, her primary, her neurologist, her endocrinologist, her psychiatrist, the specialist for her condition, and her home care aide, which was me prior to the pandemic. She is fully nonverbal, which means not only does she not speak, but she doesn't use any formal communication systems. And this is why it's so important that she has her care team. I know from the way she touches my arm in the car, whether she wants a snack or the radio turned up or is just done being in her car seat. I know all the subtle cues that come before a seizure, and I know how to care for her through her seizures and keep her safe, because hers can be violent and quite dangerous. I know how to balance her various medications to give her the best quality of life. This is a child that cannot just go to anyone. She needs her people. It takes us weeks to train a new person to communicate with her and to provide the level of support that she needs. And it's not just her that needs support. This child is being raised by her incredibly dedicated grandma, who is also taking care of grandpa. It's very physical work. This child is not small, and she's not that young. She regularly goes multiple nights without any sleep, and she cannot be left unsupervised. So grandma also goes multiple nights without sleep. This is a family very much in need of home care services. When we began to see community spread of COVID-19 back in March, the family and I had no choice but to pause home care services because their entire household is considered medically fragile. I spent some time running errands and gathering supplies and medication for them, but I could not help with the rough days or the sleepless nights. We tried to find out if there was any support for healthcare workers, if there was a healthcare bubble or access to rapid testing for healthcare workers, but there was no existing infrastructure. I have not seen the family since the beginning of the pandemic, which is good because we actually did contract COVID in my house. My husband tested positive for 7 weeks straight while I was negative and showed no symptoms. Our story is far from unique. Because of my advocacy work, I spend a lot of time talking with families with young children. The process of finding quality caregivers is an extremely discouraging process, even in our current system, even under the best of times. Compensation for this work is below a living wage, and as such, it's a near impossible task to attract people who are educated and experienced enough for these positions. Many families either go without care or are forced to pay out of pocket for services that are supposed to be provided by the state. It can be difficult for home health workers to be able to afford to do this work alone. Many of us have to supplement our income with other jobs, and this is why I only take one home health client at a time. I am incredibly passionate and well qualified for this work, but unfortunately, I just can't afford to take any more. I believe that if we had already put in place a strong healthcare network with living wages and affordable benefits, I would have been in a better position to go into a healthcare bubble and continue to provide services. Instead, families across the entire country are going without care because exposure risk is too great when their home healthcare workers all have additional jobs. Families in the disability community need support. Their home health workers need support. We need living wages that will allow us to fully devote ourselves to this work as a legitimate career rather than being treated and compensated like glorified babysitters. We need to start treating home health as a legitimate branch of healthcare so that we can adequately serve our communities, because under the current system, they are not being served, they're being left behind. Thank you.
Thank you. Thank you.
Hi everyone, can you hear me okay? Great. My name is Christine Gammon. I'm actually also a PSU Public Health alumni myself.
Yay.
I'm currently the executive director of a nonprofit called Magic Wheelchair, which promotes inclusion and self-expression for children with disabilities. I also serve on the Wheel to Walk Foundation board, which provides durable medical equipment for those who are denied or underinsured. I myself have a disability called spinal muscular atrophy type 2. It's a neuromuscular disease. It's degenerative. Basically, I can feel everything, but I can only move one finger on my right hand, which is how I'm clicking through my notes and hitting mute and unmute. And as you see, I have a wheelchair and a ventilator for speaking. So I'm able to live independently, work, run this business, and even travel because I have this trained team of caregivers who understand all of the nuances of my disability. And that situation, as you've heard, is not unique. All of us have special needs, and our teams know what we need. Someone can look at me and know if I need my arm moved, or hear a discrepancy in my breathing and know if I need suction. And those are the critical skills that we need from community and home-based services. Now, to connect to what Crystal said, she illustrated that people with disabilities are being left behind in home care and community-based services. And I just wanted to echo that. You guys have touched on it already, but trying to incentivize caregivers to live more cautiously or to reduce their number of clients without having the funding to actually incentivize them has been a big barrier for everyone in the disability community. Assistive technology has been a challenge, shortage of medical supplies and getting access to disinfectants, providing PPE for our workers, providing testing for our workers. Really how the message has been received is that the onus is on us to stay safe and to stay healthy and to stay out of the hospital. So our nonprofit has pivoted a bit to virtual mentoring and making PPE, but I myself was actually hospitalized early in the pandemic, and I felt the direct effects of the visitation guidance for acute care facilities. And I've focused all of my free time since then on advocacy for people with disabilities within the hospital setting. Early on, we saw these terrible headlines coming out of hotspots about critical care triage and ventilator rationing, but in Oregon, we had this innocent assumption that those things wouldn't happen here because our numbers were great, and we just thought the ADA would somehow, prevent this from happening. But hospitals took this policy literally. They turned to it and they relied on it. So in communities, reducing movement and slowing the spread made absolute sense. But in the hospital setting, it actually removed basic human rights of people with disabilities, and it increased exposure to COVID due to the increased movement in and out of the rooms by folks on the COVID floor. So early in April, alarms began to sound about how this was affecting the disability community or multiple communities. And we quickly rallied together and developed and passed Senate Bill 1606, which is legislation requested by the Disability Rights Oregon, the Oregon Council on Developmental Disabilities, and Developmental Disabilities Coalition. Essentially, this bill allows for people with disabilities to have a support person with them at all times while hospitalized. It also prevents hospitals to require post agreements or for folks to be coerced into signing DNR or DNI. Their treatment can't be conditioned on having those documents. So that was a huge win. I received a lot of messages from hospital workers thanking us because their patients needed more support than they could physically provide. And so I hope this new law means that Oregonians with disabilities can have the peace of mind that they won't become another tragic story or a headline in the news over simply seeking medical care, COVID or not. But can we be sure that that's the case? Can we be sure that people with disabilities will be protected? In our work in developing the language for the bill, we actually had to pull a section that simply reiterated our basic federal rights, and that had to be pulled in order for it to be passed. And then also this conversation about the crisis standards of care. It's concerning where many of us feel it's necessary to kind of present an elevator pitch about why our lives are worth saving. And so we need to reassess those metrics and hear from the community more about how to move forward. We've all had to do this. So I'm just, there's so much to talk about, but I'm just here to ask you all, how can we support you in future decision making and policy making? How will you elevate the lives and the voices of people with disabilities as we continue to navigate this pandemic? How will you prepare for and implement policy and policy exemptions that actually ensure the rights of people with disabilities and uphold the ADA? I thank Oscar for actually saying, not about us, without us. I greatly appreciate that line. This summer was the 30th anniversary of the ADA, and paired with COVID, it's evident that we need another push for a revolution that ensures the inclusion of people with disabilities across the board. So I hope you see this as an opportunity to really make history in the way that Oregon protects, supports, and includes people with disabilities. Thank you. I'd love to answer any questions and hear more about your goals.
Thank you, Christine, Crystal, and Wes. I'd like to open up to questions and comments from the board.
I don't know that I specifically have a question for any of you. I think what Christine, your comment and your challenge to us around how we elevate questions and supports and policy for people with disabilities feels like it's a gauntlet. And I personally accept that. And I find great inspiration in your presentation, all three of you, and feel more informed today than I did even earlier this morning. So I would say, in terms of encouragement back to you, continue to educate people like myself and others, you know, as we think about how inclusion and what that looks like in terms of public policy. So thank you. Thank you is my comment to all three of you.
And thank you. I think it's a compliment in some way that those policies were taken so literally. You are the final word, and you have the power to make these changes and make a difference and really make history. So I thought, you know, it was unfortunate what happened, but I think it's reassuring that they followed the rules.
Thank you.
I don't have a question, but I also just have a comment. And thank you so much for today's presentation. I really appreciate hearing more about some of these challenges that are happening. And I too will sort of take this presentation and carry it with me, and not just, you know, make sure to include people with disabilities when I'm advocating also for representation of BIPOC, but also people with disabilities. And I'll be kind of advocating for also having somebody from on the health policy board that is that comes from that community as well.
Yeah, well said. And really proud to have you at both as alumni of our school, and please use the OHSU PSU School of Public Health as a platform to raise more visibility and attention to this. And I think you have my email, and so I look forward to finding other opportunities. With that, I want to thank everybody, Dr. Castaneras, Melanie Barlow, Christine Getman, Crystal King, and Wes Lividay for their taking the time to share with the board. The purpose of these discussions is to keep us in touch with what's happening, how COVID is impacting various communities around the state. We can't travel with COVID-19, but through Zoom, I think we can hear voices that we might not have heard otherwise. So there is a silver lining to this, in that we can, you know, hear a greater range of voices and experiences, and understand the richness and complexity and impact of COVID-19. So thank you all for sharing your thoughts, your stories with us, and we're really very grateful. We have about 10 minutes left in our meeting, and I would like to devote the last 10 minutes to thank Zeke Smith, who this is his final board meeting. Zeke joined our board in 2013 and is the longest serving Oregon Health Policy board member, and still right in there, making contributions with every meeting. And we want to thank Zeke for his great contributions for the last 7 years. I personally want to thank him for his strong and gentle leadership as chair of the Oregon Health Policy Board. Set a great example with thoughtful questions and highlights important issues that we often missed, and today is no exception. And so I really appreciate him encouraging us all to do our best, both as board members and members of OHA. And Vice Chair Arana, would you like to make a comment?
Sure, thank you. What can I say? Zeke, thank you so much for all your years of service and commitment on the board. I really hope you feel incredibly proud of all the changes that you've been able to make while being on the board. You have certainly accomplished a lot during your time. CCO 2.0 was guided under your leadership. The board's Health Equity Committee was created, which has now led to a state definition of health equity and the creation of a new health equity measure. Not to mention what I'm guessing is probably your greatest accomplishment on the board, which was convincing me to join the board. But seriously, we're gonna miss your leadership. We know you're not going to go too far away, and I know you're going to stay connected to Oregon. The state of Washington is so fortunate to benefit from your leadership and your unwavering commitment to racial and health equity. I'm really excited to see what you do in that role, and I really hope Oregon will be able to recruit you back at some point in the future. So thank you for all your work, and I hope others from the board and OHA staff will also say a few words.
I'll go next. Zeke, you're the kind of person, I kind of think about that old TV advertisement of when Zeke Smith speaks, people listen. Something about the gentleness of your voice, the way that you can ask a really compelling and thought-provoking question, and the subtlety in which your leadership is actually manifested in the Oregon Health Policy Board. I personally have been impressed to witness you in that role. I'm thinking about how you navigated the leadership transition for the OHA director role. When I think about the longevity, and even as you welcomed me as a new board member, I felt incredibly supported and inspired. So thank you very much. And I wish you the very best in your future endeavor. Thank you.
Go ahead, John.
Zeke, it's been great. What I think in my case, 4 years or so. What I'd especially like to thank you for is I think you were very active in insisting that the Health Policy Board meet outside of Portland and get to other places around the state. And I remember especially Lakeview, and because we got to see what you were doing in your other job. And I just love that, and miss that. Hope we get back to it. And I want to thank you for supporting that so strongly and all the other wonderful things you've done. Thank you, Zeke.
Kristen?
I would just like to echo so many of the comments others made. I had very similar thoughts as to Brenda, just in that, like, sometimes we'll be saying something like, he's saying it so calmly, and it's a good example of like sending a strong message and challenge with just effective calmness. And so you've been a pleasure to watch. Whether I first met you on the task force a long time ago, so I'm going to miss your kind of camaraderie when it comes to price and dealing with the cost of healthcare and digging in on those details. But I'm so confident that you will continue your incredible work in Washington, and I think that'll just make our region even stronger. So have a great time.
Pat?
Well, Zeke, I want to echo and amplify everything that everyone else has already said, but I also want to thank you for your support as chair for the agency, and for me when I kind of dived in the deep end of the pool, first starting at OHA. And I think especially helping us really navigate through CCO 2.0. Working as I came to realize that we weren't going to generate 2.0. I think I overused the phrase that at best we were going to come up with CCO 1.1. And so working through the issue of the delay and restarting community engagement and all those kinds of things, and through your support and guidance, I think we as an agency together with the board came out with a vastly superior product than we would have otherwise. And your leadership really helped lead to that. So thank you for that.
Jeremy?
It's hard to follow all those comments, Zeke, without just repeating them. I just want to thank you for, I think it's been great working with you for the last 7 years, worked with you through multiple agency directors and multiple different roles with lots of different issues in front of us in a given day. Really want to echo, I think, the comments around you've always, I think, really known what question to ask and how to phrase it in a helpful way, and have really appreciated that, and appreciated your sense of wanting to figure out how to kind of work through an issue together and get to the other side. So I wish you all the best of luck, and you're going to really be missed on the board.
And can we go to Rosenda too? I know we don't have her video, so it's hard to see her at the top of the list sometimes.
Oh, okay. Shall I go ahead?
Yes, please.
Oh, all right. Well, I haven't had an opportunity to know Zeke that long, very long. It's been not, I guess it's been a year now. But anyhow, I know when I was first appointed to the OHPB, I was, you feel a little nervous and you figure out now, what am I going to do? What have I gotten myself into? You're just not sure. You've read everything, but then yet you're a little apprehensive. And, but I know when I got on board and Zeke sat a couple chairs down from me and, right away I knew, this is going to be okay. And I think it was because of Zeke and how he was on that day. And so, but anyhow, I'd like to thank him today because I was a little bit emotional through some of the things going on and some of the things being said. And I thank him and Oscar because sometimes things, when they hit pretty close to home, you don't speak up, and I'm so glad that they were here today, and everything that they said, I agree with, and even though I didn't say anything at the time, and I'm glad that they were here today, and I'm certainly going to miss him. And I know a few people in Spokane. I used to serve on the Healing Lodge Health Board up there, and that was a real great opportunity too, so I'm sure he'll get involved with that group, and also the Spokane tribe and Kalispell tribe and Coeur d'Alene tribe. So I know we'll run into each other again, but thank you for everything.
Thank you, Rosanna. Very well said. Zeke, any last words for us? Words of wisdom you want to leave us with?
I'll keep it short. First of all, if I would have known this was happening, I probably would have had something that took me away for the last 20 minutes of the meeting. I'm working on my graceful acceptance of acknowledgement, but I'm not very good at it. So, so I want to thank you all for the kind words that you said today. I really appreciate it. I have appreciated my time on the board. In that period, I feel like the Health Policy Board has really established itself in terms of the role that it can play in the larger health community in Oregon. I also am really pleased to see the Oregon Health Authority leadership and staff continuing to put more and more focus and emphasis on health equity. Today was such a wonderful meeting as a place for me to leave. I valued throughout the meeting a number of different points. Having the workforce committee come back and really lean into some of the guidance and feedback that this committee gave it about prioritizing behavioral health in thinking about the kinds of providers that the state is going to need as we move forward. That felt really great. I think the right dialogue and back and forth and push and tension really around what our membership should look like for boards and committees and structures that are intended to really support health for all Oregonians. And then I just appreciate the staff continuing to bring stakeholders in front of us, and the ones today in particular spoke to me in a number of ways. And it was great to hear board members also acknowledge how your presentations today will be taken with them. So I'm really excited for the role of the Health Policy Board. And my last statement I would make is just an encouragement for people, Oregon Health Authority staff, Oregon Health Authority leadership, policy members, community members. There's such power in acknowledging and recognizing the ways in which we still have a long way to go, and the ways in which our systems are still really not designed effectively for a number of our populations and communities that really need our services the most significantly and need the right kind of supports, as we heard today. And so just would ask that you all continue to use your voices and to use your seats that you sit in to elevate and surface those realities and to work together on addressing health equity and the issues that are there. And I leave knowing really strongly that we have people in a number of different places who really share that commitment and are eager to make a difference. So thank you for that, and thank you for this moment. Really appreciate it.
Godspeed and farewell. All right, well, with that, we'll close our September meeting of the Oregon Health Policy Board. I want to thank staff. Thanks so much for helping organize. Trilby and everyone. Pat and Jeremy, really appreciate the good work that you do. And thank you for our community presenters and all the board members. So we look forward to reconvening in October. Be well.